Hello, my name is Ann Kelsey Lamb, and I'm the Director of RAMP, Regional Asthma Management and Prevention. I'm so pleased you're watching this video. RAMP's mission is to reduce the burden of asthma with a focus on health equity. For many years now, we have worked to increase access to asthma home visiting services for people with poorly controlled asthma. Robust evidence shows that these services improve asthma outcomes, reduce healthcare costs, and reduce disparities. But for far too long, communities with a high asthma burden haven't had the resources or support to provide these services. Fortunately, that's starting to change. In California and other states, we're seeing community groups, health departments, state agencies, and others access various policy and financing mechanisms to support these services. In this webinar, you'll learn more about what asthma home visiting services are and how they can serve the needs of your communities. You'll also hear from tribal leaders about why these services are important and how they can help address a range of environmental issues common to tribal communities. You'll also learn about free technical assistance, tools, and other resources to help you incorporate asthma home visiting services into the work you're doing to support community health. This webinar was originally recorded on June 3rd. While it's a few months old, the main message has not changed. Asthma home visiting services can support efforts to address the inequitable burden of asthma in tribal communities. We hope you find the webinar useful and inspiring.
Good afternoon. My name is Joel Irvis. I'm the Associate Director of Regional Asthma Management and Prevention, a project of the Public Health Institute. I'm here today with my colleague and RAMP's Director, Ann Kelsey Lamb. We're so pleased to talk with you today about asthma home visiting services for tribal communities. Before we dive into today's subject, there are a few logistics to cover. To prevent distractions, I ask everyone to remain on mute until the Q&A session later this hour. If you have any questions during any of the presentations, you're welcome to add them to the chat at any time. And then lastly, we will email slides later to all webinar registrants. As for today's agenda, I'll provide a few opening remarks before introducing one of our guest speakers. We'll talk a bit about the challenges related to housing and environmental triggers facing many tribal communities. We'll then provide a brief overview of the asthma home visiting model and its various components. Our next guest speaker will then showcase a success story from the Northwest Portland area Indian Health Board. We'll close things out with an overview of the wide range of technical assistance tools and supports that are available for anyone with an interest in incorporating various pieces of asthma home visiting services into your tribal-related efforts. We'll also look forward to answering any questions you may have. We're very grateful to be able to conduct this webinar with support from the U.S. Environmental Protection Agency and the North American Development Bank as part of a technical assistance agreement. I would like to note that although the tasks and activities set forth in this agreement have been funded in whole or in part by the EPA and the Development Bank, such tasks and activities do not necessarily reflect the policies, actions, or positions of either organization. Since this is the first time we've connected with many of you, I'd like to share a bit of information about RAMP. Our mission is to reduce the burden of asthma with a focus on health equity. We don't provide direct service to people with asthma, but we support those who do. We build the capacity of the asthma field by creating and disseminating tools, providing strategic guidance, and conducting training and technical assistance. We also create linkages among partners for peer learning, collaboration, and network building. And we mobilize our networks to advance policy and systems change. As noted in our mission, much of our work is focused on reducing asthma disparities. As I'm sure many of you already know, while asthma may not be the most prevalent disease in tribal communities, it does indeed disproportionately impact tribal members. Here in California, for example, 1 in 4 tribal members has asthma, and tribal members are more likely to have asthma and more likely to go to the emergency department or be hospitalized compared to white Californians. The kinds of disparities that we see across many different communities of color and low-income communities don't happen randomly, but are the result of a wide range of policy and program decisions that create social and environmental inequities. Examples include racist planning decisions that concentrate higher levels of air pollution in certain communities, years of redlining and disinvestment that lead to substandard housing, and underfunded healthcare systems that limit access to high-quality medical care. To talk more about some of these social and environmental conditions and the importance of addressing them through asthma home visiting services and other efforts, I'm pleased to turn it over to Dr. Shasta Gon. She's the Environmental Director and the Tribal Historic Preservation Officer for the Pala Band of Mission Indians in Pala, California. She received her PhD in anthropology from the University of New Mexico in 2011 and her Master's of Legal Studies in Indigenous Peoples Law from the University of Oklahoma in 2021. She's involved in multiple groups and associations, such as chairing the National Association of Tribal Historic Preservation Officers and serving as the tribal co-chair for the US EPA Tribal Science Council. She's also the director of Pala's Tribal Climate Health Project, and I'm so pleased that she's with us today. So with that, I will turn it over to Shasta.
Thank you, Joel. I appreciate that. And I am happy to see all of the folks who are online so we can have this conversation today. I do not have slides. I decided I just wanted to talk to all of you person to person a little bit about what I have learned in my work, especially through the Tribal Climate Health Project, when it comes to the disparate impacts of climate change and, as Joel pointed out, a lot of other factors on the incidence of asthma in tribal communities. Now, here in Pala, we are in northern San Diego County, Payumkawacham territory, Luiseño, also the home of the Kupangawacham or Cupeño people. And we have a lot of asthma in our community. And the incidence of asthma has been increasing as time goes by, not just in tribal communities, but as a whole. But yet, as Joel pointed out, we see a much greater incidence of asthma in tribal communities. And I think a lot of you, I recognize some of these names online. I know where you work or where you live. And I think that just like Paula, you have a lot of the same factors contributing to greater asthma incidence in your communities. One example is we have a lot of high heat in this region. Well, what does heat have to do with asthma? What we're discovering is that there are a lot of other things that are triggered by high heat. One important example is that there is a greater concentration of ground level ozone when the heat gets high. And ozone is a lung irritant. If you have asthma and you're breathing in higher levels of ozone and it's hot, then that is potentially going to trigger an asthma attack in those who are already diagnosed or those who are otherwise vulnerable. And not only that, you're breathing in other pollutants besides ozone. Many of our tribal communities are full of dirt roads. And when we have people driving on those roads in high heat conditions or in dry conditions, a lot of dust gets kicked up by those roads. That can also exacerbate asthma symptoms for people in our community. Now, we know from climate change that this is not going to get better right away. Hopefully it gets better at some point, but it's going to get worse before it gets better. So there are things that we need to do to protect our community. Mostly children are the ones that we tend to think of as having asthma as a big impact on their health. But it's not just kids. Adults can have asthma too, and it can even be diagnosed in adulthood. So you've got folks whose homes are on dirt roads or have a lot of loose soil surrounding their homes where wind, high heat, wildfire, these are all things that can pick up and throw around those pollutants that get into folks' lungs and trigger these asthma attacks. Anywhere from a minor difficulty breathing all the way to something that could be an emergency where you're going to need to call public services, or I should say emergency services. But emergency services also aren't necessarily real close to the reservation. You may have ambulances or a fire department, but that fire department or that ambulance still has to take somebody who's having a severe asthma attack all the way into a hospital. So what are we doing here in Pala? There are some things that we are trying to do that we hope are going to be more protective for our community members. So one example is we have an air quality monitoring program. Hopefully some of you who work for tribes and have tribal environmental departments have been able to take advantage of some of EPA's air quality programming so that you can monitor levels of pollutants in your community, not just ozone, but a lot of PM10, PM2.5. Those are the PM meaning particulate matter, that those are the particles that get into the lungs and can cause illness and disease. So we're educating our community members about what those things are and the level that they might encounter on any given day in Paula. So there are programs where you can show flags of different colors that indicate, are we having a poor air quality day, a medium air quality day, or hopefully a good air quality day. We also have strategies where we can let people know if there is wildfire smoke that might be drifting into the community and into their homes. Even if the fire is not visible from Paula or nearly, directly close by, that smoke drifts on the wind. And we're seeing that happen throughout the United States, not just in Paula, not just in Southern California. But just because you don't see the smoke doesn't mean that really dangerous particulate matter is there. And not to put our next speaker on the spot, but I think the Pacific Northwest has started to encounter that smoke drift in ways that we in California have become a lot more accustomed to and are used to, but you have to find ways to keep that out of your home. So there are things that we can do, such as outfitting our houses with better filtration systems, whether that's through an existing HVAC system, or if you don't have home cooling and heating, you can put better filters around your windows in terms of making sure that holes are sealed around windows and doors so that the dust doesn't get in. There are even these nifty do-it-yourself sorts of ventilation systems that you can make with a box fan so that you can help keep some of those irritants that get into your home out of your lungs. It's also really helpful to know when those conditions are really poor. So maybe this is the day that it might be a sunny, beautiful day, but the kids don't go outside to play that day. You keep them in the house, or you keep them in a place where they're less likely to be exposed to those irritants. Now, the reason I'm really happy to be partnering with Joel and Anne and with RAMP is because they're offering a service where they can do home visits for you, for your community, to come and do assessments of your living space to see if there are things you can do to help keep those asthma triggering pollutants and particles out of your family's living space. And also, I think, you guys will have to correct me if I'm wrong, but do assessments to see, what your vulnerability is to asthma. Just things that you can do to keep your family safe. And this is so important because, like I said, we see these levels of pollutants increasing all the time. We see the climate changing and increasing the risks that our kids, our elderly, ourselves are going to be exposed to these dangerous irritants. And we need to do everything we can to protect ourselves rather than just ignore the fact that things are getting worse. There are ways that we can protect ourselves. So we're going to learn a little bit more about that with our following speakers. And I was just wanting to give you an overview of what I've seen in Paula, what I know is happening in some of the other communities in California, tribal communities, but it's not just here, it's everywhere. So I'm really glad to be able to turn this back over to Anne so she can give us a little bit more of an overview of what it is that RAMP can provide and how they might be able to work with us, with tribes, to help protect our families and our communities from asthma. Thank you.
Thank you so much, Shasta. We really appreciate you providing that context and really queuing up how asthma home visiting services can help address some of the issues that you described. So again, I'm Ann Kelsey Lamb. I'm the director of RAMP, and I'm going to take the next few minutes to describe what exactly asthma home visiting services look like. There are typically 3 different components of asthma home visiting services that happen over a span of several visits, and I'll touch upon each one. Next slide, please. For the first component, a community health worker, community health representative, promotora, or other professional meets with a family in their home to provide culturally relevant asthma education. The education covers basic asthma facts, the use of different types of medications, self-management techniques, and self-monitoring skills. Sometimes asthma home visiting clients may have just been diagnosed with asthma. Maybe they ended up having an asthma attack and had to go to the emergency room or urgent care clinic, and they need a lot of information about the disease and what it means for them. Other times, clients may have had asthma for a long period of time, but never received much education as part of their medical care, so they're eager to receive information too. Next slide, please. For the second component, the home visitor works with the family to conduct an environmental asthma trigger assessment. They'll look for things like signs of mold and moisture or pests like cockroaches. They'll work with the family to understand whether there's exposure to things like environmental tobacco smoke, chemical irritants from common cleaning products, or nitrogen dioxide from gas stoves or space heaters. There are tried and true tools to help with the assessment, like the one pictured here. Next slide, please. Following the assessment, many asthma home visiting programs provide supplies or services to help remediate the asthma triggers that they've identified. The remediation is essential for improving asthma management. Even someone with the best clinical care who is following their medication regimen perfectly will continue to have asthma exacerbations if they're regularly exposed to asthma triggers in their homes. Providing pest management services to eliminate cockroach allergens, helping a family find ways to reduce moisture and get rid of mold, and giving a family an air cleaner to help reduce exposure to wildfire smoke. These types of supplies and services truly make a difference in the lives of people with asthma. Next slide, please. I want to take a moment to talk about who provides asthma home visiting services. There's evidence showing that these types of services can be provided effectively by a wide range of professionals, from community health workers and representatives to lay asthma educators to social workers and respiratory therapists and others. No matter the job title, what's critical is that the home visitor is able to build trust and rapport with the client through cultural humility, knowledge of the community's cultural beliefs and practices, and the ability to speak the language of the client. Evidence suggests that it is this trust and rapport which helps motivate and empower the client. In our work over the past 2 decades, we have seen community health workers, promotoras, and community health representatives be particularly effective, as they are often from or have extensive connections to the communities that they serve. Next slide, please. Another way to visualize this is to look at different pieces of a puzzle that make up asthma home visiting. In 2019, the state of California allocated $15 million to support asthma home visiting programs. 28 asthma organizations, including community-based organizations, local health departments, and health clinics, were funded to provide asthma home visiting services for 3 years. An external evaluation team identified 6 components of successful asthma home visiting programs based on the initiative pictured here. So here, the model of success is comprehensive asthma education and trigger remediation provided through in-person and/or virtual visits by community health workers practicing culturally responsive and patient-centered approaches. Next slide, please. There is robust evidence showing that these programs work. Asthma home visiting is an evidence-based intervention that has been proven in study after study to improve asthma outcomes, reduce healthcare costs, and reduce disparities. Studies have shown that asthma home visiting services reduce emergency department visits and hospitalizations, improve asthma control, decrease symptom frequency, decrease work and school absenteeism, improve quality of life, and importantly, reduce asthma disparities. So I've talked at a broad level about what these programs can look like. I thought it'd be useful for you to hear additional details from a specific asthma home visiting program. To do that, I'm very pleased to introduce Sean Blackshear, the Director for the Environmental Public Health Division at the Northwest Portland Area Indian Health Board. He began asthma trigger identification home visits in 2015 at the Indian Health Service Yakima Ambulatory Health Clinic. He is a licensed registered sanitarian in Washington State, and he brings 25 years of environmental health work experience to 27 Pacific Northwest tribes. Sean, thank you for joining us today.
Well, thank you very much for that introduction, Ann. That sounds like I really know what I'm doing here. So, yes, I'm Sean Blackshear. I appreciate you all giving me the opportunity to speak to you today. I'd also thank California to quit sharing their wood smoke from wildfires with us. So y'all just keep that. You can go to the next slide if you would, please. So the health board is basically a nonprofit organization that is funded through Indian Health Service, 638 funds. All of the tribes have set aside a certain amount of money to fund the board. They started out in the 70s as an epidemiological outfit that would look at specific data looking at Native Americans. Currently, with the environmental health program, we serve 27 Pacific Northwest tribes, and there's where they're all located there on the map. Actually, there's a few in there that are, I think this is the map of the 43. So there's 43 federally recognized tribes, and we serve 27 for the environmental health program component. Next slide, please. So we developed a comprehensive childhood asthma program at the Yakima Nation. We also had another tribe participate as well in Idaho. It basically ran with three components. We had referrals from the medical clinic, or portion of the clinic had the pharmacy, and then the home visits. Next slide. So at the Yakima Indian Health Center, that is a medical clinic that's located on the reservation in Toppenish, Washington. And with a grant from the National Institutes of Health, we developed a program where we looked at child patients with moderate to severe asthma. They were invited to participate in our study either through the clinical side with the doctors or pharmacists. But all the referrals to the environmental management program came from the pharmacy. So that we, and reason we did that was that patients better associated that with the clinic or having the medical need versus me just cold calling and asking to do a home visit. So when it was the pharmacy that called the patient and asked for an appointment to be set up, we had better response from that because they associated it with the health clinic. Next slide. So with the pharmacy, we made that our hub of information flow. So they had access to the charts. We started out with giving me access to the the electronic health record. But I had other duties as assigned doing inspections. So I wasn't a dedicated asthma educator. So it was better for the pharmacy to act as the centralized location. They also not only did referrals, but when I completed my inspections, that information was uploaded to the patient's chart, and a notification was sent to the primary care provider so that they could review that at the next asthma visit. Also, the Indian Health Service pharmacy would go through a medication review and gather data from their visit with the patient. So they had their own protocol and education regime. So not only was I giving them education, but the pharmacy as well as the doctor. So they were getting it at least from 3 different sources. And then the home assessment was flagged in the electronic health record so that the clinical provider could see what the results were and provide further information if they needed to. Then they would actually sign off on the note that they had read that a home assessment had been done. Next slide. So our environmental health assessment, didn't look too differently than what Ann had presented. We would go in and interview the patient, do a walkthrough to identify asthma triggers. There were several occasions where things like scented candles or scented air fresheners were being used in the home, and the parents were not aware that that was a potential asthma trigger. So almost guarantee I'd find at least one asthma trigger that the patient or the patient's caregiver had not identified. Participants received intervention materials that are common for asthma triggers. So, green cleaning supplies, encapsulating bedding, so a slip cover for their mattress, box spring, and their pillow. We'd also do a medication review during the visit. And then any identified asthma triggers, we talk about how to reduce or remove those. And then we were not funded to do any home repairs, but if anything was identified that needed to be repaired, we try to work through the local tribal housing department to get assistance there. Next slide. So Yakima Reservation is the largest by square miles reservation in the Pacific Northwest. It has a broad environmental context. It's mainly agricultural and horticulture, and so that you have things like animals and pollens, especially when the cherry trees and the apple trees are blooming in the spring. Next slide. So what does a home visit look like? You make the initial contact, go in, bring in cleaning supplies, and then go over each item, and then in these slides here, actually either go over we were not funded to provide air filters, but if they had one, we'd go over how to use them, where to place them, and when to change the filters. And then that picture to the right, I'm installing a insect sticky trap there. So trying to educate them on not using pesticides, but use traps and baits. So next slide. Also, to get participation or increase it and keep it, because there were 3 visits, we would bring the green cleaning supplies, which you see here, and then also we were able to provide 2 $25 gift cards to the local grocery store, one for the parent for participating, and then one for the child. So it was, a little bit of bribery because the child wanted their $25 gift card. So it was good. So, they would remind mom or dad or the caregiver that, we need to do the asthma home visit again so that they could get their incentive. So we had good participation with that. And then we also provided a HEPA vacuum cleaner and then supplies to deal with the common asthma triggers, and then some monitoring equipment for indoor humidity, some lead paint tests, and then there's a indicator for the smoke chimney, the flue, to see how, if you're burning the wood at the right temperature, make sure that your wood burning stove is not too cold and producing smoke, and not too hot where it's causing damage to the fireplace. Next slide. So some of the major things that we saw was clutter. So we tried to inform our participants about how to manage that, and that stuffed toys and other items can collect dust. And so we'd have them put those stuffed animals, either in the dryer if they could handle the heat, or you can put them in the freezer overnight and kill any dust mites that may be in there. Next slide. Another common trigger we saw was pet dander. So along with trying to take care of the dust in the homes, so remind them to clean window coverings, blinds, and drapes, but also have a designated pet area, put slip covers on upholstery if you're going to let the pet on the furniture, and also either try to remove the pet from the bedroom if they're allowed to sleep in there, or at the very least, wash the bedding frequently with hot water. Also trying to control dust with wet cleaning at least weekly. Next slide. High humidity, especially see this in the winter months. Folks try to get their homes as tight as possible to try to keep the heat in. And so trying to educate folks on the fact that a home actually needs to breathe and needed to bring in fresh air was one of the other items that we saw quite often. And also educating them that you can have air that's too dry. It's not humid enough. So we would try and help them make sure that the relative humidity was between 40 and 60% ideally. And so we gave them a humidity meter. Also, high humidity in the bathrooms. We have lots of water sources there. Either opening a window or keeping the ventilation fan on for 20 to 30 minutes after the bath or shower has taken place. Next slide. And another issue we saw quite a bit was water leaks, either supply lines or drain pipes. Saw a lot of mold because of that, especially underneath kitchen sinks. And also trying to educate our participants that dirty dishes are a source of humidity, and having that around gives a water source and a food source to insects and rodents. So making sure that those dishes are clean and been put away and dried. Next slide. Reducing exposure to smoke. The Yakima Nation had a trade-in program for their old wood-burning stoves through US EPA. And so if I noticed that there was a wood-burning stove that had leaks or was missing fire bricks or had cracks. And one home I went into, the smoke was just pouring out. I think there was more smoke pouring out of the firebox than there was going up the flue. So getting them in contact with Yakima Nation Environmental Management Program to replace that stove was critical. And then for those who smoked, if they were not willing to go through cessation, and we provided information on how to get help with that, to at least reduce the smoking inside the home, going outside to do that, wearing a smoking jacket or cover so that the particulates accumulated on that, and then that's left outside instead of on their clothing, where they bring that back in and it off gases inside the home. Next slide. And then obviously while we were there, we want to make sure that we're identifying any other safety risks that could be a risk to life and safety. So bad electrical connections, just anything you can see as an environmental health person that needs to be fixed, and educate the patients so they don't get harmed. Next slide. A critical part of this study was the medication review and usage. The pharmacy was extremely good at reviewing the patient's medication usage. If they saw that they were just refilling the rescue medication, the ProAir or the albuterol, they would make note of that and let me know as well, so that I could reinforce the fact that they needed to use the long-acting inhaled steroid as a preventative. Younger children, I'd ask if they had a spacer or not, so that they could do a better job of getting the medication into the right, lower lobes of the lungs. Next slide. Here's what a write-up looked like after a home visit. We write out the recommendation for changes, ask or update the asthma action plan, and then follow up with housing for necessary repairs, and then facilitate communication between the folks in the health clinic there. Follow-up visits were every 6 months, and when we did a follow-up, we would check off and see if they had done any of the action items that we left them with, and also try to identify any new ones that may have cropped up or weren't identified in the first home visit. Next slide. So the study enrollment, what did we find? 67% of the clinician referrals from the health clinic participated in our program. We had 43 patients enrolled at the beginning for the first home visit, and then we had 22 that went the entire year and did a follow-up. So that means they did the initial 6-month and then the final inspection. The other tribe that participated was Nez Perce in Idaho. They had 20 patients that enrolled, and they had a little bit better participation to the end. They had 19 folks out of 20 do the 12-month follow-up. And then COVID-19 happened in, what was that, 2020? And so that had to put a big burr under our saddle with that. So we ended up going to a virtual format where we gave patients tablets that they picked up at the pharmacy. And then we would review all of the patient information, and then I would have the participant take the camera and zoom around the home and try to identify asthma triggers that way, going through each part of the home and asking to have them video specific areas. It wasn't the best, but it was the best thing we could come up with at the time, and so it served its purpose. We still got some visits in there. Next slide. I didn't have to go into the home. So what were the key findings? Our child patients, and this is both for Nez Perce and Yakima, that both populations had mild to moderate asthma. So that's actually pretty good news. That means that we were doing a good job. There was room for improvement, but there were not a ton of severe uncontrolled asthmatics in our patient population. Next slide. I think one of the key points to mention that helped with that is that the pharmacy ended up getting it's called an AIM, asthma inhaler monitor. It allows the pharmacist or asthma educator to grade the technique for proper use of their inhaler, whether it's a HFA or an inhalation long-acting steroid, so powder. And we saw that 75% of the patients had improper inhaler use techniques. They weren't putting the medicine where it needed to go in their lungs. So patients either inhaled the medicine too quickly, did not take enough breaths or deep enough breaths for it to get into the lower parts of the lungs, or didn't hold their breath long enough for it to settle. Also, we would educate patients on how to use a peak flow meter to show, how bad their asthma was, and whether they needed to use their rescue inhaler or not. Even though you're not getting an audible wheeze, you can have tightness that doesn't make it apparent that you need to take your rescue inhaler. So we made sure that they got education on peak flow meters as well. Next slide. So as a summary of the home visits, 78% of the homes showed at least one lasting environmental modification or habit modification. So, pet-free bedroom, install doormats to collect dust from the outside, try to knock it off before it gets into the home. Installing and using the encapsulating, bedding for the pillowcase and box spring and mattress. We, at the very end, after a year, we had at least one habit or environmental modification. So that was good result. Next slide. And then we saw an improvement on days missed from school. In the past 2 weeks, it went up by 16% of kids actually attending school and not calling in because of asthma. We saw a reduction in the same day appointments that were needed for asthma. We also saw the emergency department visits go down. So we asked, how many emergency room visits did you do in the past year? And if they answered 0, then people that actually answered 0, we didn't go for a year, went up significantly. And then 80% of that threw me. 80% of the patients at the end of a year, the ones that participated that long, 80% said that they felt that their asthma was well controlled. So I'll let you guys ingest that a little bit longer. And then whenever you're ready. So the asthma quality of life and urgent care visits due to asthma improved after 1 year participating in the program. So on the left side of the bar is where we started at the baseline, and then for well-controlled asthma. And so at the end, 12 months, we showed that 80% as opposed to whatever that was, 60, whatever that is, 68, 67. And then just another way to look at the data, emergency visits. So recommendations, if you're planning on doing this yourself, and I failed to mention that our green cleaning supply kits were mirrored after the Tulalip tribe's Tribal Healthy Homes Network. They helped quite a bit in sharing what they put in their green cleaning supplies and what they also give for controlling the asthma triggers, to their folks that they take care of. So sorry, going back to recommendations, include all necessary collaborators. So, make sure you've got the clinic on board, the pharmacy, and the pharmacy was housed within the clinic, and our tribal folks go there quite often, not only just for medical care, but also to have their medication refilled even if they don't have a medical provider at that clinic, they're still eligible to get their medication filled through the pharmacy. So that was helpful in recruiting patients. Environmental health. I would also say at least for us, the tribal departments, so housing, water and wastewater as well. They would come in, and Indian Health Service. They would come in and replace septic systems if they were not up to par and were causing issues with mold because the system's not draining properly. So there's other partners out there. For instance, RAMP. If you have access to folks like that, definitely get them on board. They're extremely helpful. When you have all these folks together, you need to agree on and designate a department that will do the coordination. If you can find a champion or someone that can be the center of the information hub, that was actually critical. We had done this before the study, just as a pilot project, and that was one of the things that was lacking. So we fixed that with the study. It was very helpful. I would recommend that the home assessor needs to be well versed in not only asthma education, but home inspection. So those are two diverse schools of knowledge. So trying to find somebody that can do both can be hard sometimes. So you may have to train people up to where they're proficient in both. Build trust. There's numerous times when nobody wants to have a stranger come into your home and start poking around and telling you how you're doing things wrong. So definitely, go in with a sense of humility. Let them know that you're there just to help, and you're not there to judge. I had a lot of folks that once they saw what we were doing, were more than welcoming the next time I came by, and we're really doing a lot to address their child's asthma. Make incremental changes. Try to address the largest triggers first, the ones that you're going to see are going to potentially cause the biggest problems. If you leave them with a laundry list and it's huge, it's overwhelming. So try to start out with baby steps. If you can get the first large triggers addressed in the first visit, then you can go after the other triggers that you saw in the second visit. It gives the participants or the patient a sense of accomplishment that, hey, I can do this. But if you lump everything on them at once, it's almost overwhelming. And then communicate with the medical providers. Make sure that there's some way that your clinicians are getting the information, because, this is a quote, a doctor said, all I see are these four walls. The patient comes in, tells me the information, and he goes, I have no way of verifying if that's true or not. So it's critical to get that information back to the medical provider so that they can also provide the education that the patient needs, because ultimately we're not doing it for them. They've got to take the bull by the horns and make those changes, make sure that they're lasting. Next slide. Okay. And just remember, you can't eliminate every asthma trigger. It's just try to do your best to do environmental management strategies. Make sure that the patient's using their medication. Proper control of asthma can be achieved, and the result is living a life that you want. So you can't eliminate all of it, but try to do your best. And I think that's the end of that. Oh, here's some toolkits and websites. So there's Tribal Healthy Homes that I mentioned. We've also, the study that we did, we developed an asthma toolkit for tribes. And next slide. And here's a way to contact us if you're interested in more information. Thank you.
Sean, thank you so very much. I really appreciate you sharing details of your program. So thank you very much again for being here today. For the rest of our participants, hopefully you now have a better sense of both the value of asthma home visiting services and how they generally work. So next, I'm going to talk about the no-cost tools and technical assistance and other resources that are available to anyone who's at all curious or interested in your organization providing asthma home visiting services. First, I want to acknowledge that despite the burden of asthma in tribal communities, asthma may not be a current priority for you or your colleagues' work. And we certainly understand and respect that. In fact, in the various conversations we've had with tribal representatives or staff from tribal serving organizations, we often heard about other pressing issues that tribal members face. And on the slide are just a few of the topics we heard. So when RAMP talks about asthma home visiting services, we really see them as building upon any efforts that you might already be implementing rather than replacing those efforts. In other words, home-based asthma services can be a way of providing even more comprehensive supports for some of the community's most vulnerable members. It's also important to note that asthma home visiting services are not an all or none proposition. So if you don't have the resources to provide comprehensive asthma home visiting services, or you simply have other priorities you're focused on, you can start with just a piece of asthma home visiting services. So as an example, if your community already has home visitors that conduct diabetes education, the home visitors could be trained to provide asthma education as well. Similarly, you could provide air cleaners as part of a wildfire response approach and later build on it with asthma education or other supplies. It might also be helpful to think of the components of asthma home visiting services as tools in your toolbox. So the tools that you choose are up to you depending on community needs and available resources and your overall capacity. Of course, we understand that providing services requires resources. So the good news is that there are sources of financial support for asthma home visiting services. And by combining different funding strategies, programs can sustain their services over time. So we've seen programs use foundation grants, healthy housing funds, environmental justice grants, donations for supplies, and other strategies to support their asthma home visiting services. EPA GAP grants are another potential source for capacity building related to program development. We're also seeing a shift within Medicaid. So here, Medicaid managed care plans or state Medicaid programs are starting to see the value of asthma home visiting services and are providing both short and longer term funding for them. As just one example of that exciting shift here in California, Medi-Cal now has 2 policies in place to support asthma home visiting services. One policy covers education and environmental trigger assessments in the home. The other covers environmental trigger remediation in the home. And together they have the potential to expand access to asthma home visiting services for low-income Californians with poorly controlled asthma. The policies can also help improve the financial sustainability for asthma home visiting programs so that they're here not just now, but for years to come. And that includes new programs. With the adoption of these policies about 2 years ago, we're seeing new asthma home visiting programs launch in underserved communities, which is really wonderful. So while the support for asthma home visiting services from California's Medicaid program is exciting for those of you who are not in California, I again want to stress that there are multiple ways to fund asthma home visiting programs. This infographic from the EPA highlights various sources that you might tap into for different components of these services. So for example, you might tap into state and local health departments to fund asthma self-management education and look to healthy homes or weatherization funding for environmental trigger remediation support. While the need to braid funding to provide comprehensive services can make the process a little bit more complicated, there is an upside. So diversifying your funding increases your ability to make it through a funding downturn that comes from any one source. So if the idea of bringing any asthma home visiting services to your community is at all of interest, you don't have to tackle it alone. So RAMP would be delighted to help you. So just to revise something that was said at the top of the hour, we don't provide direct services ourselves, but we provide support to groups that want to provide those services. We currently have a cooperative agreement with the EPA to provide free technical assistance to groups across the country to increase access to these services and build sustainable programs. So we combine our technical knowledge around asthma home visits with your really local understanding of the needs, strengths, and opportunities within your community. So with support from the North American Development Bank, we also have additional capabilities to assist tribes along the California and Arizona borders. What does that support look like? Well, first of all, we start with what you need and want. We provide responsive TA or technical assistance rather than pushing an inflexible one-size-fits-all approach. That includes helping you assess whether asthma home visiting services are even a fit for your efforts. So, to say it a little bit differently, if asthma home visiting services are a door, we can work with you to decide if it's one that you want to open and walk through. We can provide lots of guidance around program design, including sharing best practices from other programs so you don't have to start from scratch. And we can help right-size your work, whether you want to start with something small, like a pilot program, or go big with a larger scale effort. That means, considering ways to leverage any home-based work that's already happening in your community. We can help you think about sustainability from the beginning of your efforts so that these services will be effective for years to come. So pictured here is a tool we designed with our partners at the National Center for Healthy Housing called the Roadmap for Asthma Home Visiting that essentially helps support you in designing a path forward that works best for you and your community. We can also support your program by pointing you to commonly used tools that have been developed by us or by others in the field. Asthma home visiting services have been around for over 20 years, so that makes it actually easier to take something and modify it for your own needs rather than developing something from scratch. And here are just a couple of examples of the different tools for different needs that are utilized. We also worked with the National Center for Healthy Housing to develop e-learning modules about building and sustaining in-home asthma services. These go-at-your-own-pace modules can help you develop and expand all aspects of an asthma home visiting program. To close things out here, we are strong proponents of peer learning. So we lead numerous networks that provide opportunities for connecting with others as well as collective action. So for example, there are many other organizations that are very willing to share their own experience as well as learn from yours. That includes peer learning both with program management staff as well as home visiting staff. So for example, we convene community health workers and other asthma home visitors on a regular basis. I want to flag just a couple of other resources that may be useful for you in your work. For example, if you are in California and are interested in seeing if asthma home visiting programs already exist either in your area or near your area, you can check out our asthma home visiting directory of programs across California. It's organized by county for easy browsing. And if you don't find what you're looking for, feel free to reach out to us and we'll see what we can do to connect you with another program that could be of service. In terms of other resources, last year we published a range of resources related to making smart and healthy choices in purchasing portable air cleaners. And Shasta mentioned this, the particulate being a really significant issue for her community and many tribal communities. So these air cleaners are being used more and more by families, schools, and businesses for wildfire smoke events and other pollutants. We publish an e-newsletter that includes a wide range of funding opportunities, events, resources, and studies related to asthma and how to address it. And for those of you in California, we lead the Community Action to Fight Asthma network that's comprised of members of the asthma field across California. You can learn a lot more about these and other issues at our website, rampasthma.org. So we have covered a lot of ground over the last hour, and let me pause and just see if there are any questions that anyone has for me or for our other speakers today. You're welcome to raise your hand, put a question in the chat. Happy to take your questions. Any questions from anyone? While you all are mulling things over, I will just say that certainly we would very much appreciate it if you could take literally 2 minutes to answer a few questions about this session. Your feedback is very valuable for us as we continue this work. So you can scan the QR code with your phone, or I will also put the links in the chat. I'm having a little trouble with my chat, but we will follow up via email with the links in case you can't get to the QR code. Finally, thank you so much to Shasta and Sean for sharing your expertise and perspectives. And thank you all for attending today's session. We very much appreciate the collective work you are all doing to address asthma. Have a wonderful afternoon. And if anyone has any additional questions, I'm happy to stick around for a few minutes to talk those through. Thank you again.